Good afternoon, everyone. I'm Pedro Barri. It's my pleasure to welcome you to this webinar. Unfortunately, our chairman, Andrea Genassani, cannot make it because of last-minute commitment, and I will chair this session in which we will cover two very interesting issues. First, I will explain what we clinicians must know and what can we explain to our patients when they have mosaic embryos and which are the clinical decisions to be taken. And the second speaker of this afternoon session is Maria Teresa Almeida Santos, professor of obstetrics and gynecology at the University in Portugal, at the University of Coimbra. And Maria Teresa will cover the topic of fertility preservations in young oncologic patients suffering from ovarian cancer. Okay? Starting with my presentation, with my talk. Just a second, I'm trying to share the screen with you. So the title of my topic is Getting to Know the Clinical Value of a Mosaic Diagnosis. Is it time for a change in mosaicism reporting? We all know what a mosaic embryo is. A mosaic embryo is an embryo that has two different cell lines, one being abnormal or aneuploid, and other being euploid or normal embryos. And what happened with these mosaic embryos in the last years, when we start to be able to detect embryo mosaicism, we were really afraid of this condition, and most of the embryos, as you can see here, were discarded because of the perception of a high risk for the baby that was supposed to be born after this embryo transfer. More recently, we have received information of a large series of cases in which mosaic aneuploid embryos were transferred into the uterine cavity and normal babies have been born. And this make all the embryological and clinical community to analyze the research and to find out the clinical outcome that could be obtained with this strategy. And we came to the final decision that most, or at least a vast majority of these mosaic embryos could be transferred and could produce a normal pregnancy with the birth of normal babies. In our experience at the Hospital Universitario de Sceus here in Barcelona, as you can see here, we had in the analyzing our material, almost 35% of our embryos were euploid with a normal chromosomic pattern. Half of them, 51% of the rest of the embryos were abnormal, were aneuploid, and 13% of the remaining embryos were mosaic. What does it mean, mosaic? Mosaic means, as I said, that these are embryos in which normal and abnormal cell lines coexist. And in this 13%, as you can see here, 7% were totally abnormal. So the two cell lines were aneuploid. However, there was a 6.5% of mosaic embryos in which there were most of the cell lines were normal, were euploid. If we analyze the cycles affected by mosaicism, in our PGT cycles, most of them, 78%, no mosaic embryos were obtained. So this means that in 22% of the cycles, mosaic embryos were obtained, of which there were cases in which only mosaic embryos were obtained, and cases in which mosaic and euploid embryos were obtained in parallel. And if we consider the percentage of cycles in which only mosaic embryos were obtained or not having achieved live birth of a transfer of the euploid embryos, so this accounts for 7.9% of our PGTA cycles. When we were afraid some years ago about the risk of these mosaic embryos, because there were no bibliographic references reassuring about the positive and low risk outcome, we did not advise patients to receive these embryos, and most of them were discarded. In 2018, when some evidence arrived, 1/3 of our patients accepted to transfer a mosaic embryos. But look what has happened in the more recent years. In 2022, when this international publication with more than 1,000 embryos, mosaic embryos, being transferred and confirming that there was not an increased risk of fetal abnormality, 60% of the patients accepted and were willing to receive these mosaic embryos. When these articles were published, the first one with 1,000 embryo transfer of mosaic embryos, and another study with 400 cycles with the transfer of mosaic embryos, in which the authors analyzed their development potential in a prospective non-selective selection clinical trial. These articles confirmed that there was some clinical findings that when mosaic embryos were transferred, these are the initials of mosaic embryo transfer, it seemed that there was a reduced cumulative pregnancy rate, an increased miscarriage rate, and a reduced live birth rate. But apparently there was not an increased risk of fetal anomaly. When this new information arrived, we were able to analyze the very important data from these studies, and the first thing to be taken into consideration was the two parameters. One, the mosaicism type, and the other, the mosaicism level. The mosaicism time, we consider that there is a mosaicism in which only a segment of the chromosome is affected, is what we call a segmental mosaicism. And another type is the type in which the whole chromosome is affected by the mosaicism. Of course, it's better a segmental mosaicism than the whole chromosome mosaicism. And there was another parameter to be considered, is the degree, the level of mosaicism. And as you can see in this cartoon, the most favorable outcome was obtained when mosaicism was segmental and with low level of mosaicism affecting 1 or 2 chromosomes maximum. When more the chromosomes were affected and it was a complex mosaicism, of course, the prognosis was affected and the clinical outcome was impaired. It's very important, this study published by Antonio Capalvo and his group, in which they analyzed the development potential of human preimplantation mosaic embryos in a context of a clinical trial, and they classify these embryos in normal euploid embryos, low-grade mosaic embryos, and moderate grade of mosaic embryos. And as you can see here, they compare three groups of embryos. Group A, in which embryos transferred were normal, were euploid. Group B were low-grade mosaic embryos with a maximum level of mosaicism of 30%. And group C, medium-grade mosaicism, with a percentage of mosaicism of 30 to 50%. And if we compare these three groups for positive pregnancy tests, biochemical pregnancy loss, miscarriage, live birth, twin delivery, gestational age, and birth weight, no single difference were observed. What does this mean? That from a clinical perspective, a mosaicism below 50% could give a final result as good as the result obtained with the transfer of euploid embryos. And if we consider the pool of mosaic embryos transferred and registered in the literature, with more than 2,700 embryos, mosaic embryos transferred, there was only one case of a confirmed mosaicism. So I think that these results are reassuring. And what probably the mechanism behind this situation, because in a mosaic embryos with normal and abnormal cell lines coexisting in these embryos, most of the abnormal cell lines, most of the abnormal cells underwent apoptosis or are confined to the trophectoderm, to the placenta, and the remaining embryo is healthy and totally euploid. We have some reports confirming the birth of embryos healthy or affected because after the transfer of a mosaic embryo, this is the first birth of a baby with mosaicism resulting from a non-mosaic embryo transfer. This was a baby which was healthy, and this baby presented chromosomal abnormality in the peripheral blood, but the buccal smear at the birth was totally normal. And we have also two interesting articles in which a mosaic embryo was transferred and a baby was born with a non-mosaic partial aneuploidy and uniparental disomy, and this was an affected baby. And two cases of clinical reports of mosaicism confirmed with PGTA persisting during pregnancy as a true fetal mosaicism. And both cases were the gestation, the pregnancy was terminated, was interrupted. But all in all, if we consider these four cases, in the 2,700 mosaic embryos transferred, this means that the risk observed with the transfer of these more than 2,700 mosaic embryos, the risk was 0.14%. And the general population has a risk of 2%. So this means that we are at a lower risk than the risk observed in the general population. Another important point for us clinicians is that when we compare the copy number loads to decide the degree of mosaicism, this study, again from the Antonio Capalvo's group, has shown that if the percentage, the degree of mosaicism was below 50%, this cutoff value of 50% provide the highest sensitivity and specificity rates. And this is why we consider that these mosaic embryos with a degree of mosaicism below 50% that theoretically could be transferred with low risk for the babies. What happens with the embryo biopsy for the PGTA analysis? And we can have clearly classically consider abnormal results with abnormalities arising from meiosis, some cases in which all cells were aneuploid, all cells presented segmental losses or gains, some trisomy embryos, some cases or with uniparental disomy or chaotic diagnosis. These cases, embryos should never be transferred, and the recommendation is do not transfer. There are, in green, we have embryos in which not a single abnormality has been detected, and these embryos can be considered for transfer. And in between, in yellow, we have cases in which an abnormality has been diagnosed, but it's an abnormality that is possibly compatible with normal live birth. And this is post-zygotic mosaic aneuploidy and post-zygotic mosaic segmental gains and losses. And in these cases, patients should be referred to a genetic counselor to inform properly about the outcomes and the risk. And with the decision will be taken according to the level of mosaicism, the lower the better, of course, the chromosome involved, the prospect for a rebiopsy and reanalysis, and if there are other embryos, euploid embryos to be transferred instead of these mosaic embryos. And also it will be interesting to have information about the morphokinetics of these and other available embryos. And these embryos can be transferred. Which are the ESRI guidelines on chromosomal mosaicism? And these guidelines are very clear. This comes from 2022, and the summary of these guidelines is: first, it is not acceptable to discard low-range mosaic embryos, as we used to discard 5 years ago. Rebiopsy and reanalysis of embryos with a mosaic result is not recommended. So we don't need to rebiopsy these embryos. When selecting embryos among euploid and low-rank mosaic embryos, PGTA results should be co-evaluated with embryo morphology, of course. Another important recommendation is that low-range mosaicism in a trophectoderm biopsy does not represent an indication for invasive prenatal testing in case of a pregnancy. And a specific recommendation relevant to the potential transfer of high-range mosaic embryos could not be formulated. Which are our recent data from our hospital, the Hospital Universitario de Zeus here in Barcelona, our recent data on mosaic embryo transfer. We have in blue euploid embryos. In yellow, we have mosaic embryos, and differentiating low-grade and high-grade mosaic embryos. If we consider cumulative pregnancy rate, 56% with euploid embryos, 49% with mosaic embryos. This is combination of low-grade and high-grade mosaics. If we subclassify and with low-grade mosaics, 51% clinical pregnancy rate, no difference at all. If we consider the high level of mosaicism, pregnancy rate drops significantly to 36%. The opposite happened with the miscarriage rate. Miscarriage rates are the same with euploid, overall mosaic embryos, and low-grade mosaic. But if we consider miscarriage rate with high level of mosaicism, although the numbers are reduced, the miscarriage rate we have obtained is 50%. And this translates in an ongoing pregnancy rate in which we have not observed differences with euploid, overall mosaic, or low level of mosaicism, around 45, 41, 46%, but the ongoing pregnancy rate with high level of mosaicism drops again to 18%. So, which, according to all this information, which are our proposals? What we have decided in our program is that we consider embryos euploid when they are totally euploid, or even when they are mosaic, but with a level of aneuploidy below 50%. So all these embryos can be transferred with the same chances of achieving a pregnancy, a low level of miscarriage, and a normal fetal outcome. And we have also analyzed the prenatal and perinatal and postnatal outcome when comparing the outcome when euploid embryos were transferred and compared to the group in which mosaic embryos were transferred. And as you can see here, for prenatal and perinatal outcomes, no difference in pregnancy complications, in delivery complication, in the C-section rate, gestational age was the same, and prematurity below 37 weeks of gestation rate was the same. And as for the postnatal outcome, no difference were observed in the fetal birth weight, the Apgar score, congenital anomalies, and hospital admission. I think that these results are reassuring, and this is why we consider that mosaic embryos with a level of mosaicism below 50% can be considered as euploid embryos and can be transferred, and we can offer to this patient a normal chances of pregnancy and fetal outcome. Thank you for your attention. I'm ready for any question that may arrive from the forum. It's my pleasure now to introduce Professor Maria Teresa Almeida Santos. As I said before, Maria Teresa is professor of OBGYN at the University of Coimbra in Portugal. And Maria Teresa is very well known in the international meetings and international journals for her contribution to the field of human reproduction. And today, Maria Teresa will present her talk on fertility preservation in ovarian cancer. Maria Teresa, the floor is yours.
Thank you very much, Professor Barri, for this kind introduction. It's always a pleasure to share the stage with such a person like you. It is, in fact, my pleasure to present to the audience some perspectives on fertility preservation in young women with ovarian cancer. Of course, this is a difficult subject because the organ that its function we wish to preserve is the same that is attained by a tumor. But fortunately, recently, two papers have been published that can help us on this discussion and also on the shared decision-making with young women with ovarian cancer. In fact, in February 2024, a paper was published under the auspices of ESGO, and ESP, and it's a consensus conference recommendations on ovarian cancer, mainly on the staging and follow-up. And in August this year, in Lancet Oncology, guidelines from ESGO, and ESG were also published on fertility-sparing treatments and follow-up in these patients. So we have two recent important papers that will guide us on this presentation. As you all know, ovarian tumors are not frequent among reproductive age women. In fact, germ cell tumors are the most frequent at this age, but only 3% of them are malignant tumors. Borderline tumors affect women of fertile age, about 1 in 3 tumors at this age, but fortunately, most of them are diagnosed in an early stage, at stage 1. In fact, ovarian cancer is not a cancer of young women. In fact, less than 15% of them occur before 45 years old. But unfortunately, more than half of them are at the metastatic disease at diagnosis. So when we have a patient with ovarian cancer, we have to think about what kind of treatment we will offer to her and about her wish of conceiving, what age she is, and what we can do to treat her, sparing the fertility possibilities, if it's possible, of course. So fertility preservation is also always a difficult consultation, because we want to have informed patients and shared decision-making. But in ovarian cancer, this decision is even difficult than in other cancers that occur in young women. So we must, of course, do this appropriate staging in order to see if we can spare fertility during surgery, and also see what kind of treatment will be necessary after surgery, namely if we need chemotherapy, if we can do something to protect the ovaries from the gonadotoxic effect of agents, or if we can spare some germ cells or some gonadal tissue in order to be able to have a subsequent pregnancy. The papers that I've mentioned are very clear on the good prognosis of some ovarian tumors, provided that adequate staging and follow-up are done. In fact, in early stages, mainly stage 1, the prognosis is not dependent on the type of the tumor, and the global survival at 5 years is very high. Although the recurrence risk is not so low as we would wish, but the follow-up, the adequate follow-up, will detect recurrence as soon as it is possible. This kind of traffic light that was published guide us on the indications for in vivo ovarian tissue preservation in young women with ovarian cancer according to histological type and staging. As you can see, for borderline ovarian tumors, you can spare ovarian tissue without affecting the prognosis, no matter what stage the tumor is, and the same thing can be said for germ cell tumors. But for all other ovarian tumors, only stage 1A will allow the preservation of ovarian tissue in vivo, except for small cell carcinoma and settle Leydig cell tumors. And there are, in fact, some tumors where we can leave ovarian tissue in situ in stage 1C1. This is the way of presenting it in a less graphical way. So for borderline tumors, if there is a limited disease, of course, we can do either cystectomy or unilateral salpingo-oophorectomy, which is preferred because of the lower risk of recurrence. But we may consider that second salvage surgery may be necessary because of possible recurrent borderline lesions on the contralateral ovary. In fact, at pathological examination, we can find minor foci of typical endometrioid adenocarcinoma. When we have a germ cell tumor, also we can do a salpingo-oophorectomy, unilateral, and even spare the fallopian tube if it is not adherent to the tumor, and then complete surgical staging and having good results on oncological safety and reproductive outcomes, even in stages like stage 3C. For epithelial tumors, the treatment that is recognized is, of course, salpingo-oophorectomy with complete surgical staging. And in stage 1 patients, fertility-sparing surgery doesn't hold a higher recurrence risk, and it can be performed if the tumor is encapsulated, well differentiated, and in fact unilateral with no extraovarian metastasis, adhesion, or ascites. For clear cell carcinoma, the unilateral salpingo-oophorectomy plus full peritoneal staging is advised, is recommended in stages 1A and 1C1 only. For sex cord stromal tumors, it's almost the same, but it's needed to do a complete bilateral pelvic and paraortic lymphadenectomy. In the opinion of some authors, it's not consensual. So, what are the cases where cystectomy, bilateral cystectomy, would be advisable? According to the guidelines, bilateral ovarian cystectomy with macroscopic health ovarian tissue sparing can be done in bilateral serous and seromucinous borderline tumors. It's a recommendation 4B. If we do unilateral salpingo-oophorectomy and cystectomy, we will have a higher recurrence rate, but it won't affect the overall survival, having in fact better fertility results, that it's easier to understand. What about follow-up in this type of surgery, fertility sparing surgery? What is advised is a follow-up every 3 to 4 months for the first, second years, then every 6 months for another 3 to 5 years, and then annual follow-up for at least 10 years. Of course, this follow-up is sorrowful. It would have a physical and ultrasound examination. Pelvic and abdominal CT or MRI should be performed at 6 months and then annually until the 5th year. A measurement of the antigen 1 to 6 concentration may be useful only when it was initially elevated or when other presurgical markers are missing. PET-CT is only indicated in cases where we suspect that a recurrence may be occurring. As we talk about chemotherapy and gonadotoxic effect, we can divide the agents that we normally use into low or no risk agents like some alkylating agents and antimetabolite agents, in high risk agents, which are most of the alkylating agents, namely cyclophosphamide, ifosfamide, chlorambucil, melphalambucil, sulfan, procarbazine, and medium risk agents, which are the ones that are normally used in the chemotherapy of ovarian tumors, namely platinum-derived, which will cause chromosomal damage and DNA cross-links. When we consider taxanes, it is controversial. They are mitotic inhibitors, but we know that paclitaxel can damage mature oocytes. So, according to the risk of the agents that we will use, we will classify them into medium risk, or high risk agents as far as treatment of ovarian cancer is concerned. So it is advisable to discuss fertility preservation options with these young women. Of course, we can also think about agents that can protect the ovary from the insult that is caused by the gonadotoxic agents. But unfortunately, until now, these agents are only being used in research studies. Only GnRH analogs have been used, but they are not efficient in preserving the ovary from the effect, the gonadotoxic effect of chemotherapy. So we must use more efficient methods in order to spare fertility. And the more efficient methods that we have are, of course, cryopreservation of gametes. We can cryopreserve oocytes, we can cryopreserve embryos, or we can cryopreserve gonadal ovarian tissue. It depends on the countries. The cryopreservation of embryos is the most efficient way of preserving fertility, but it is not a good one because it does not respect the women's autonomy, reproductive autonomy, because these embryos will only be able to be used with a couple, if there is a couple. So we are not preserving the women's autonomy. And we tend not to use it anymore, even if in the States it is highly used. So in Europe, we use the cryopreservation of oocytes or the cryopreservation of ovarian tissue that we will see the differences between both. What is the cryopreservation of oocytes? When we have reproductive age women that is post-pubertal and we can wait 2 weeks before initiating chemotherapy, we can stimulate the ovaries with gonadotropins like we do for ART and collect mature oocytes that will be vitrified and kept in liquid nitrogen until they will be used for in vitro fertilization later on when a pregnancy will be desired if the fertility is not spared. So it is something that we are used to do. It's easy to do, but it can have some disadvantages over the ovarian tissue cryopreservation, where we take part of the ovarian cortex, we cut it in ovarian tissue slices, and we freeze it, also of course in liquid nitrogen, for later use. The later use will be by transplantation of these slices, of these strips of ovarian cortex that can be grafted in the ovarian medulla if there is still an ovary remaining, or they can be grafted in a peritoneal window. If it is a risk of transferring malignant cells, we should not use the strips of the ovarian cortex, but we can try to isolate primordial follicles from these strips in order to transfer only follicles that will be included in a matrix in order to be safer. So we can transfer these follicles included in kind of a gel, making kind of an artificial ovary, and this is still a research method that would mimic the transplantation of the strip without the disadvantage of having malignant cells that would cause a recurrence. There is also a lot of research in trying to do the in vitro maturation of the follicles and the oocytes from these primordial follicles in order to use them for in vitro fertilization. So this risk of transferring malignant cells is present. There are, as I'm saying, a lot of teams that are working on trying to avoid this risk, but until now this is not useful in clinical pregnancy we have to use other methods in order to try to avoid or to mitigate the risk of transferring malignant cells, like studying one piece of tissue and looking for markers of the tumor or for neoplastic cells in this piece. Of course, this will not ensure that the pieces that we will graft will not have malignant cells, but it's what we have today. So, how should we counsel and assess ovarian function in patients before cancer treatment? The assessment of ovarian reserve in ovarian cancer patients is exactly the same as we do in women without cancer. So we should measure anti-mullerian hormone and do a natural follicle count, but we must interpret with caution the results in patients with ovarian tumors because they can be affected. The most important marker is still the age of the patient. So the younger the patient is, the better prognosis, of course, we will have both with oocyte cryopreservation or ovarian tissue cryopreservation. Let's look on the pros and cons of oocyte cryopreservation. Of course, using this technique, you don't have the risk of transferring malignant cells. You keep the reproductive autonomy of the women. You avoid ethical and religious issues that are concerned with embryo cryopreservation, and you can use it even in patients carrying high-risk genetic mutations such as BRCA mutations, which are a common cause of ovarian cancer in young women. However, there are limitations for this technique because using ovarian oocyte cryopreservation, you cannot restore the endocrine function of the ovary. Of course, we have seen that ovarian cancer patients may have a lower response to ovarian stimulation. Of course, you cannot do it in prepubertal girls where only ovarian tissue cryopreservation is possible, but there are still other limitations, which are the risk of a small risk of malignant cell dissemination during the oocyte collection, an hypothetical delay in oncological treatment because you need 2 weeks to have oocytes that are ready to be collected, and a small risk in estrogen-dependent tumors because every ovarian stimulation will cause a rise in estrogens. The pros in high-risk genetic mutations are evident because in this kind of patients you shall not use ovarian tissue transplantation because there is an inherent risk of ovarian cancer. In fact, after completion of family planning or at the time where prophylactic surgery, namely salpingo-oophorectomy, is recommended in these patients, the ovaries should be removed in order not to have a higher risk of ovarian cancer. In low-grade serous or ovarian endometrioid adenocarcinoma or granulosa cell tumor, you should also think about the possibility of doing an oocyte collection ex vivo. This means that you can stimulate the ovary before surgery and try to aspirate the oocytes from the follicles just after the removal of the ovary in the OR. This will be easier without the risk of splitting cancer cells. In fact, there are already several reports of success in ovarian cancer patients, both using immature oocytes that are matured in vitro, or both using other type of oocytes that are vitrified. So the technique works and can be used, of course, always after an extensive staging and a discussion with the patient and the multidisciplinary team, including, of course, the oncologist, the reproductive medicine specialist, and also a psychologist. And what about fertility preservation after recurrence in ovarian cancer? It's, of course, more difficult, but there are guidelines. So fertility evaluation in patients with recurrent borderline ovarian tumors who wish to preserve their fertility is mandatory before any treatment, and this will be done with a comprehensive multidisciplinary team. Ovarian stimulation followed by oocyte retrievals in advanced stage borderline ovarian tumors is feasible as long as there has been a complete resection and pathological evaluation that confirms that there are no implants. So it is important to have this team, this experienced team, to be able to be sure in this type of techniques. For malignant germ cell tumors, fertility preservation strategies should be discussed on an individual basis in a multidisciplinary team for women previously treated for an immature teratoma and that have a recurrence highly suspicious of benign or growing teratoma. Of course, in cases of recurrence of sex core tumors, we cannot undergo any fertility preservation strategy. So, a little more information about ovarian tissue cryopreservation and transplantation. You can see here the strips of cortex that we have after removing all the medulla and the primordial follicles that we try to preserve. So after removing the ovarian cortex, we skip two of the strips that go to histopathological examination in order to ensure that there are no malignant cells and also to evaluate the density of primordial follicles that will be that will dictate the prognosis of this treatment for fertility and for also for endocrine restoration. After that, we freeze the pieces. As I've already told you, later on, when the patient is cured and wants to have a pregnancy, if there is still an ovary remaining, even if it's an atrophic ovary, we can transplant the strips and graft them in the medulla of the remaining ovary. If there is no remaining ovary, you can still transplant them into a peritoneal pocket. And this is the seminal work from Marie-Madeleine Dolmans and Professor Blanes that have reviewed a series of almost 300 women in 5 leading European centers of fertility preservation. These numbers are very encouraging because almost 90% of the patients achieved ovarian function restoration. 1/4 of them had a live birth. Only 12 had recurrence of the tumor, and they were apparently not related to the transplantation. Of course, this graft won't last forever. The median graft survival is 4 to 5 years, and it's, of course, dependent on the women's age and the density of follicular reserve, and it's not dependent on previous chemotherapy schemes. Still, the best predictor of ovarian tissue transplantation success is the number of primordial follicles in the frozen fragments, which is normally correlated to the woman's age. What are the determinants of transplantation success with preserved ovarian tissue? We can see the data from 200 women from the Fatty Protect network. This group achieved very good results. After the first ovarian tissue transplantation, 30% of pregnancies and 25% of live births. Of course, the live births were more prevalent among women below 35 years old and less prevalent among women more than 35 years old. In all gynecological malignancies, we can see that 10% of patients were not able to have a pregnancy, but 7% of them were able to have a pregnancy. What are the risks of transplanting ovarian tissue when we have a patient with an ovarian cancer? Of course, the risk is the one of implanting malignant cells that are able to survive freezing. So we have to concentrate on mitigating this risk by either using any technique, any molecular technique that can detect markers related to the tumor or tumor cells in the strips. Of course, the strips that we analyze in the lab are not the same that we will transplant, so there is always a small risk. But we are, as I said, scientists are developing other strategies in order to mitigate this. However, there is some advantages in using cryopreservation of ovarian tissue for transplantation. Namely, there is no delay on oncological treatment. It is, as I also already said, the only option in prepubertal girls. It might also restore ovarian function, and it might restore fertility, enabling spontaneous pregnancy. The main strategy that is being looked at and has been under research by the group by Marie-Madeleine Dolmens and Christiane Amorim is the construction of artificial ovaries. So they are trying to get this risk of recurrence by the transplant of malignant cells zero by using an artificial ovary, which is an amount of follicles that are isolated and enclosed in a matrix. In fact, even there is a risk, we believe that patients with high risk of introducing malignant cells should not be denied the opportunity of having their ovarian cortex cryopreserved, because we are believing that in the near future, developments in the technology, such as this development of an artificial ovary and also developments in in vitro maturation, will lead them to have oocytes that are mature and that will lead to pregnancy. So this is an important message. Even if we cannot exclude today this risk, we should cryopreserve the ovarian cortex if the cryopreservation of oocytes is not possible, because in the future we can be able to use them without significant risk. So I do believe in these two techniques, even if today we have not enough data on ovarian cancer. This is just to explain what is meant to be the artificial ovary, so a kind of capsule within which there are the follicles that will be grafted in the ovary. So I'd like to leave some take-office or take-home messages. Every individual who wish to preserve their fertility should be offered counseling first, reproductive counseling with a multidisciplinary treatment before the beginning of any oncological treatment. In the case of gynecological cancer, if fertility-sparing surgery did not affect the possibility of conceptions, patients are advised to attempt spontaneous conception for at least 6 months before being referred to a reproductive medicine specialist. When oocyte vitrification is considered after fertility-sparing surgery or chemotherapy, ovarian research assessment should be performed at least 6 months after surgery to allow the recovery. So only after this time we will consider using material that is cryopreserved. Thank you very much for your attention.
Thank you very much, Maria Teresa, for your excellent presentation. We have now some minutes left for questions from the virtual audience. We have 79 participants connected, so I invite you to present, to send in via chat your question. There is one question already in the chat. The participant asked me the following question: what do you counsel for mosaic embryos above 50% of mosaicism? Do you proceed with transfer but caution about higher miscarriage rate? Of course, as I mentioned in my talk, these cases, first of all, need a consultation with the geneticist and the genetic counselor to inform them about not only about the lower chances of pregnancy, but also the higher risk of miscarriage, but also about the, let's say, potential abnormalities in the fetus. That there are very few cases reported, but some of them may occur, and patients should be aware of this situation. I think that when embryos are, mosaic embryos are below 50%, you can go ahead and, and transfer the embryos, being confident that pregnancy can be achieved and a normal pregnancy and a normal baby can be born. But when high-level mosaic embryos are the only remaining embryo that this may happen, and the patient that only has a high-degree mosaic embryos, I think that these cases require a thorough discussion with the geneticist, and then the patient or the couple will take the decision to whether or not they want to have the embryo to be transferred. More questions? Why waiting for this question? I have, Maria Teresa, one question I want to address you. Is when we start in preserving fertility in young oncologic patients, and we start with ovarian biopsy, ovarian cortex biopsy, and reimplantation, regrafting of this ovarian cortex. Do you think that if we have in both hands, in one side, ovarian cortex cryopreservation and later grafting, or oocyte freezing and oocyte and embryo freezing, what do you think? Although embryo freezing, of course, has some ethical aspect that should be considered, of course, but oocyte cryopreservation, nowadays oncologists more and more allowed for a short course of ovarian stimulation and freezing of the oocytes. What do you think?
I agree with what you are suggesting. When we started in 2010, we didn't have a way of preserving the oocytes that was good enough. Nowadays, we have the vitrification possibility, which allows a very high survival of oocytes. So oocytes cryopreservation is always our first option whenever it is possible. Of course, if it is a child before puberty, we cannot go for oocyte cryopreservation. And in fact, in Portugal, we have several cases of ovarian tissue cryopreservation in young children. The youngest one is 4 months old girl. But in fact, if we can, we go for oocyte freezing. We don't use embryo freezing because it's not allowed in Portugal for fertility preservation. So we cannot create embryos for fertility preservation. We don't like the idea also because it does not allow the women to have our own germ cells cryopreserved. It's embryos that belong to a couple. And we do less and less, of course, ovarian tissue cryopreservation, only in children or when the oncologists have to remove both ovaries because a bilateral tumor and there is a small piece of a normal ovarian tissue, and we freeze this small piece of normal ovarian tissue after looking at it outside the body.
Yeah.
So this is our strategy now.
Yeah, I totally agree with you, Maria Teresa. And I don't know in your survey, because this theoretical risk of relapse after reintroducing malignant cells when grafting ovarian cortex from patients suffering, let's say, from hematological diseases or other conditions. Are you aware of clinical cases reporting the relapse of cancer after the grafting of ovarian cortex?
There are, as I told you, 10 or 12 cases of recurrence that are not linked to ovarian tissue transplantation.
Yeah.
In fact, in leukemia patients, what we do now, because leukemia children are very ill when they come to us, they have low platelets, high risk of infection. So what we do normally is to let them do 2 cycles of chemotherapy in order to try to wash the malignant cells from the ovary, if there are any, and then consider ovarian tissue removal for later transplantation. So there are only in children, because I agree with you, most oncologists now refer patients sooner. So we have the 2 weeks that we need to complete ovarian stimulation.
Absolutely. I totally agree, Maria Teresa. Let me check if there are no questions. Do you have a question for me, Maria Teresa, for the mosaicism in embryonic culture?
I have a more difficult question. I have just noticed that there is a problem in the United States that companies that do PGTA have been sued because they are selling something that is not sufficiently analyzed. Have you heard about this? Can you comment about it? Do you want to comment about it?
And are you aware of a penalty that has been given to a center in Australia, to Monash, a very important financial penalty because of the discarding what they, with common sense, they consider non-transferable embryos. And nowadays, with more knowledge and with this effect of that is universally accepted that low-grade mosaic embryos can be transferred without risk, and some patients fight and complain that they were misled and they were not properly counseled. And I think that this is an important issue, because you know that there is, I remember a publication in which only aneuploid embryos were transferred in the States, because you know that there is a fight in the States with PGTA groups versus or against non-PGTA groups. And one of these groups, let's say non-PGTA groups, they publish an article. I don't remember the number of cases reported, but there were quite a lot, and only transferring aneuploid embryos, clearly aneuploid embryos. And they obtained something like a 15% clinical pregnancy rate. So, of course, we have to be modest, and we have to accept that there is some level of uncertainty. And with mosaic embryos, it happens. How a 30% mosaic embryo can be transferred, resulting in a normal, fully normal chromosomically a baby born. And this fact that for a long time has been known and accepted that these aneuploid cells or abnormal cells were confined to the placenta, and the baby is totally normal. When we perform a trophectoderm biopsy, this is, let's say, the future placenta, and maybe some abnormal cells do not represent the whole embryo. Right? But this is a difficult issue, as you said.
I would say that we should use PGTA for ranking the transfer of the embryos instead of discarding them.
Yeah.
I think it's better to think like this. It's because like this we are doing it properly, at least.
But normally we doctors, we offer the best of our knowledge to our patients, and of course that maybe a totally aneuploid embryo can result in a normal baby. But if it was my own case, I would not be willing to receive an aneuploid embryo. So I think that we must be very careful with this, with all these issues. But what is reassuring, and this was the take-home message of my talk, is that low-grade mosaic embryos can be transferred, and we can reassure our colleagues and the patients that they do not, as Esre has said, they do not need prenatal invasive testing, and they can be considered as a normal pregnancy. Do we have more questions?
There are two questions in the chat.
I don't know. There is a question. How is this financial aspect of this managed in most countries? In Uruguay, we have a law which grants 100% finance coverage by the state to 100% of population without delay and bureaucracy. This question is for you, Maria Teresa.
So in Portugal, every oncologic patient can freeze their oocytes or ovarian tissue in the national health system without any cost. So 100% paid by the national health system. I think this also happens in some countries in Europe, but not in everyone. I don't know if you want to say about Spain.
Yeah, and Maria Teresa, the same participant asked you, how does this all apply to trophoblastic disease?
Oh, this is a difficult question. Trophoblastic disease. So after chemotherapy is finished, and if the patient has no more cancer cells either in the uterus or in the body, we can go for a normal pregnancy, because normally the drugs that we use to treat trophoblastic disease do not affect fertility. They are not in the group of high-risk chemotherapy agents. Normally, methotrexate is not very toxic, mainly.
Yeah. More questions from the virtual floor? No. If not, I think that we can close this webinar by thanking BT Congress for their support, and thanking Maria Teresa for your excellent presentation. And don't forget that the next webinar will be held on December 11, Wednesday. The session will be chaired by Professor Andrea Genassani, and the title of the session will be BVT Risk, and the speakers will be Professor Jonathan Duxfield and Professor Nathalie Chabert-Buffet. So you are all invited to attend to this next webinar. Thank you very much to all, and have a good evening and all the best. Buenas tardes, María Teresa.
Buenas tardes. Thank you very much.
Bye-bye.
Bye.
Bye.